Good evening, everyone. I'm Dr. Madhavi. I am a senior consultant microbiologist at Vijaya Diagnostics. I am I'm MD Micro with an experience of around 17 years. I've been working with Vijaya for the past 1.5 year, and I work as a senior consultant here. And today we are going to have a webinar on rapid and accurate diagnostics in clinical microbiology, the need of the hour. So basically, we are trying to emphasize on what we know about the rapid diagnostic tests that are available, and we will be stressing on the sample collection procedures, which are the most important things for microbiology, especially. And then we will be delving a little bit on rapid diagnostics as well. The presenter for today is Dr. Sachin Sumanth. He's an MBBS MD he's an MBBS from Karnool Medical College, and he's an MD microbiology from SVM's Sri Venkateshwara Institute of Medical Sciences, Tirupati. He has an experience of more than 10 years in the field of clinical microbiology. He also works as an assistant professor in Government Medical College, Nandyal. He's been associated with Vijaya for the past 5 to 6 months, and we are so pleased to have you here, Dr. Sachin. And the floor is all yours. It's over to you, Dr. Sachin.
Thank you. Thank you so much, madam. And yeah. Good evening, everyone. And thank you so much, Madhavi madam, for your kind introduction. I'm pleased to be in this webinar. And today, the topic for our webinar is rapid and accurate diagnostics in clinical microbiology, which is the need of the hour. Rapidity, the speed with which the specimen is processed and reported, but if it lacks accuracy, it holds really little value for the treating physician to give appropriate treatment. On the other hand, if the test is accurate on giving the results but fails in giving in rapid form or in a speedily form, it doesn't also help the treating physician for immediate management. So in this era of antimicrobial resistance, as you all know, we are facing a lot of antimicrobial resistance everywhere. And to reduce the indiscriminate use of antimicrobials, to reduce the mortality from sepsis, and to improve the patient outcome, we definitely need diagnostics, especially in clinical microbiology, that give us both the rapid and accurate results. Somebody said like this: if you give me a common sample, Common is a book which we treat as a gold standard for diagnostic microbiology. I will give you a Harrison's report. That is the importance of the right sample that will help us to give a very valid report or accurate report. A poorly collected sample or specimen not only results in failure to recover important pathogens, but it is also leads to incorrect or even harmful therapy. So proper collection and transport of the specimen for examination is critically very important in the ultimate confirmation of pathogen involved in the disease process. Let's look into some of the fundamentals in specimen collection. Firstly, the material must be from the actual site of infection that should be collected with minimal contamination from the adjacent tissues, organs, or secretions. If it is not collected properly, let's say if the swab is collected not from the depths of the wound, definitely it will not give us a valid report because it all contaminated with the surface colonizing agents. And for example, if a woman is asked to give a urine sample for culture, and if she inadequate cleansing of peripheral area, and especially in women, definitely is not going to give us a proper urine culture report. On the other hand, optimal time for collection of specimens must be established to provide the best chance of recovering the causative microorganisms. Especially, let's say, for example, in enteric fever cases, the causative organism must be can be recovered optimally from the blood during the first week of illness. And in urine and feces, it will be in second and third week of illness. And when it comes to Vidal test, which is a test which is widely used, only the antibodies will rise only in the second week of illness. If you try to give Vidal test in the first week of illness, definitely it comes in negative. and will miss the diagnosis. And these agglutinins will remain detectable for many weeks even after the clinical remission of the disease. Nextly, a sufficient quantity of the specimen must be obtained to perform the test required. Let's say if you submit a dry swab with scanty secretions, definitely it will result in a false negative reports, which is detrimental to the patient. And fourthly, appropriate collection devices and specimen containers must be used to ensure optimal recovery of microorganisms. For example, let's say for urine cultures, definitely that should be collected in very sterile containers. And for swabs, for swabs or throat swabs, definitely distributed with dacron or polyester is better choices than cotton or calcium alginate swabs. And for recovery of anaerobic organisms, use of swabs is discouraged rather than aspiration with needle and syringe inserted with the stopper after careful removal of the needle is recommended. This is how we can send the sample if you are draining an abscess or a pus, taking the needle and putting it, recapping it, the syringe with the cap and sending it for the lab. And fifthly, whenever possible, cultures must be obtained or done before the antibiotics are administered. Obtaining cultures before the administration of antibiotics is highly recommended, especially for the recovery of recovery of organisms which are highly susceptible to antibiotics. For in throat specimens, for beta Himalayan streptococci, and in genitourinary specimens for Neisseria gonorrhoeae, and in CSF samples for Haemophilus influenzae and Neisseria meningitis, definitely uh, we need to give the sample before the administration of antibiotics. And specimen, last but not the least, specimen container must be properly labeled. So many times we receive to the lab just stating it like a swab for culture. We do not know whether the swab is a rectal swab, whether the swab is a throat swab, whether the swab is something, a pus swab from any ulcer or some other wound. Definitely proper labeling of the specimen is very, very important so that we can detect or we can think whether the organism that is isolated is a commensal or it is actual pathogen in that particular area. Now, let's look into the specimen collection, transport, and storage, which is very, very vital in getting an accurate results and also to have a valid diagnosis for the infection. Usually in clinical microbiology, we receive urine samples, blood, pus, stool, CSF, sputum samples, and throat swab for respiratory tract infections and body fluids like pleural fluid, ascitic fluid, peritoneal fluid, pleural fluid, synovial fluid, and some genital secretions. Let's look into urine sampling and storage. Except for urethral mucosa, if you understand the human anatomy, which except for urethral and mucosa, which supports the growth of microbial flora, the normal urinary tract is actually devoid of a lot of microorganisms. It is except for urethral mucosa. So we need to collect a midstream clean catch urine sample for proper culture of the urine sample. So it has to be a midstream and it has to be a clean catch without getting contaminated from the urethral flora. That's why we ask the patients, especially for women, to clean the periurethral area and the perineum with soapy water and then rinse it normal water and collect the sample, the mid portion of the sample, mid portion of the urine that is voided. For men, definitely cleaning of the urethral meatus is needed for collecting the urine sample before and getting a midstream urine sample is sufficient. And these urine samples must be processed within 2 hours after the collection to achieve accurate counts, or else it will be overgrown with commensal flora, so which will mask actual pathogen in the sample. Then for indwelling catheters, yes, this is where we need to really focus a lot because most of the patients who are bedridden and who have done post surgery cases, they'll be kept on Foley's catheter. Now, how to get a sample from that kind of patients? Definitely, lot of times when there is an untrained healthcare professional or healthcare nurse, definitely she tried to take the urine sample from the urine bag or she tried to clamp it or disconnect the bag and take the urine sample from the Foley's. All these things, we see a lot of these kind of things. Definitely, that will give you an erroneous report of what is happening inside that patient. So, scrupulous aseptic technique is necessary for collecting urine sample in this kind of patients. For that, what we can do is we need to clamp above the port, the Foley's catheter. Then we need to cleanse vigorously the wall of the tubing, where we need to take the sample with syringe and the needle. with 70% alcohol, and urine is aspirated with needle and syringe. And the main part is the integrity of the closed system should be maintained to prevent the introduction of microorganisms, which is highly notorious to cause catheter-associated urinary tract infections. So to prevent these hospital-acquired infections, definitely we need to maintain that closed system properly. We should never open that closed system and cause a entry of the hospital-acquired infections into the patients. So that's very important for us. Important tip, important way how we can collect the sample. So it should never be collected from catheter bags, and the police tips are unsuitable for culture as they are contaminated with urethral flora and colonizing flora. And when it comes to suprapubic aspirations, which are reserved exclusively for neonates and small children, after thorough disinfection of the skin, injection of local anesthetic, and it is followed with incision and aspiration of at least 10 ml of urine from these patients. And if there is a delay in processing of urine samples, it can be stored in fridge for up to 24 hours or at 4 to 8 degrees, not in deep fridge, but normal 4 to 8 degrees centigrade, you can store it up to overnight. Then, and for urine transport tubes containing boric acid, glycerol, and sodium formate, they have shown that they can preserve the bacteria without even refrigeration for a time period of 24 hours. Now, coming to the blood sampling, which is very important. And you all know bacteremia and septicemia, the presence of bacteria in the circulatory system. The signs and symptoms may present or can be invariable, and this is called bacteremia. And in septicemia, patient suffers with fever, chills, tachycardia, hyperventilation, toxicity, and these are all because of the microbial toxins and cytokines that are released inside the body. Traditionally, it was thought this kind of septicemia will be caused or associated with only gram-negative organisms, let's say for like E. coli, Klebsiella, or Pseudomonas, with their endotoxin production. But now it is appreciated that even gram-positive organisms like Staphylococcus can also lead to septicemia in patients. There are three kinds, as you all know: transient bacteremia, intermittent, and continuous. Just a few words on this. Transient bacteremia can be seen in minor events like brushing of the teeth, can also lead to entry of bacteria into the circulation and even the manipulation of infected tissues and contamination of instrumentation of contaminated mucosal surfaces during surgery. Then continuous bacteremia is seen in septic shock, bacterial endocarditis, early stage respiratory fever, brucellosis, and leptospirosis, where there is a continuous bacteria that is shared inside the circulatory system. And intermittent bacteremia is seen in patients with undrained abscesses, where the bacteria are shared intermittently into the circulatory system. So in this way, in this kinds of bacteria, collection of blood sample is very vital. How much we have to collect, when to collect, and how to collect. So when we are collecting a blood sample, disinfection of the skin before collecting is very vital and done with povidone iodine, which requires 1 to 2 minutes of contact time, and remove that with 70% alcohol and allow it to dry. That is very important. Once to swipe the area with the alcohol, definitely we have to allow it to dry before drawing the blood culture. And obtaining blood from the indwelling intravenous or intra-arterial catheters is strongly discouraged because of the contamination that can occur with these intravenous catheters. And if an intravascular catheter is used as a second sample, used for any reason, a second sample must be drawn from the other side so that you send for comparison whether actual pathogen is grown or any contaminants have grown. This is the way, as you know, we can take the sample. Definitely, we can see a lot of times people wearing the gloves, doing all the decontamination or disinfection process, and again touching the same site with a gloved hand. So we should avoid touching it once you have cleaned and properly given the antisepsis. And number and timing of the cultures, how many number of cultures we have to take and on which time we have to do. The number of specimens collected is very less important than the total volume of the blood culture. Ideally, the yield of blood culture increases with 30 to 40 ml of blood, which is drawn in two sets of bottles, each having 10 ml, and it should be drawn ideally before the administration of antibiotics. If a patient has existing IV line, the blood should be drawn below the existing line, and blood drawn above the line will be diluted with the fluid that is already being infused. And it is not desirable to draw blood from vascular shunt or catheter because these devices are difficult to decontaminate completely. How much volume now? Because there is a direct relationship between the volume of blood and the heat. It follows that more the blood that is cultured, greater are the chances of isolating the organism. Usually for adults, we say or we advise 10 to 20 ml of blood per culture bottle, and in infants we advise or recommended is 1 to 5 ml of blood. These are all the automated culture bottles that you see, and the thing is we are advised to wait for until 3 days before drawing a next blood culture sample for culture, because most of the automated system that we have, it can detect the bacterial pathogen if at all pathogen is present, or if any organisms are present inside the blood, they will detect within 3 days. So until 3 days there is no need to draw again the blood culture sample to send it back to the laboratory for culture. So inoculate bottles should be submitted as quickly as possible to the laboratory. Now coming to the pus sample collection, there can be an exogenous wound infections and endogenous wound infections, which where there is accumulation of pus within an abscess or exuding from a sinus tract or from a mucocutaneous surface. Many wounds are polymicrobial, particularly those that are result from fecal spillage, bed sores, and infection in diabetic patients. Surface wounds usually they get colonized with environmental bacteria or nosocomial pathogens, and the surface swabs do not always reflect the true cause of infectious process. Definitely, because on the surface, suppose the swab was taken just touching the surface of the wound, and that is already contaminated or colonized with the environmental bacteria and nosocomial pathogens, definitely it will give erroneous reports. So many times we see this kind of results coming, and we go to the wards and see whether the patient, how the patient is doing, because we got all the antibiotics resistant to a particular pathogen that is isolated from a blood, from a first culture. And when we go and see the patient is quite fine, he's doing well, he's eating and he's walking, and there are no fever spikes, no leukocyte count is not elevated, he's fine and he's ready for discharge, maybe in few 3 days. But here we get an organism which is resistant to all the antibiotics, then definitely that can be a colonizer. That is, the proper sampling was not done. Proper sampling was not done correctly. So that is a colonizer that we have isolated. So that's how we have to take the correct sample to get a correct result. And biopsy of the tissue, curettage of the draining wound, or aspiration of fluid, pulse from the depths of the wound. That is very important. And abscesses are very most desirable methods for collecting the material to examine. Coming to the stool sample examination, it should be collected in a clean, wide mouth container with tightly fitting lid. Contamination with urine should be avoided. And in newborns and debilitated patients, we recommend rectal swabs can serve the purpose better. If an ethological agent is not isolated with the first culture of the stool, or with the visual examination, we could not able to find any pathogen or any kind of pathogens, two additional samples can be submitted to the lab over the next few days, as the organisms can be shared intermittently. Stool sample should reach the lab within 30 minutes, and a volume of 5 ml or a peanut-sized formed stool is adequate for most of the procedures. For the recovery of Shigella and Clostridium difficile infections, especially in hospitalized patients, rectal swabs are more preferred because these organisms are susceptible to cooling and drying. Rectal swabs should be inserted just beyond the anal sphincter, avoiding direct contact with the fecal material in the rectum. For isolation of viruses, rectal swabs sent in a transport medium called as modified Stewart's medium, or any viral transport medium, or any other viral transport medium is adequate. Coming to the throat swab sampling, especially for upper respiratory tract infections, care must be taken not to touch the oral mucosa and the tongue while taking the throat swab. The tonsillar areas and posterior pharynx should be firmly rubbed with the swab. After collection of the swab, it should be placed immediately into a sterile tube or a container for transport to the laboratory. The type of the swab for the collection is very vital here. We have a lot of swabs, like we have cotton swabs, we have Dacron swabs, we have flocked nylon swabs, we have calcium alginate swabs. So cotton swabs are unsuitable for culture because the presence of fatty acids in the cotton fibers, which will kill the bacteria like Bordetella, the causative agent for whooping cough. And calcium alginate swabs are best for bacterial culture, but if you are planning to do a molecular testing, definitely they are not preferred for molecular testings or PCRs. Dacron or rayon swabs are preferable for PCR and molecular assays. If streptococcal pyogenes is desired, swabs can be allowed to dry because during transport to suppress the survival of commensal organisms, and swabs they can withstand drying streptococcus pyogenes, and it can be cultured from the swab. And swabs for viral isolation should be placed in a special transport medium. For lower respiratory tract infections, expectorant sputum culture is the simplest and the least expensive specimen. And the patients are asked to brush their teeth, gargle with water immediately and before obtaining the specimen, which will reduce the number of contaminating oropharyngeal bacteria. Early morning sample is very desirable because it contains the pooled overnight secretions in which pathogenic bacteria are more likely to be concentrated. And the saline used for injections, they are to be avoided for giving nebulization because sometimes those preparations contain antibacterial substances. And to prevent contamination from the outside part of the container, we ask the patient to press the rim of the container on the lower lip while collecting the sputum sample. This is the few ways you can collect the sputum sample. This is also wash the mouth, rinse it, then take a deep breath and cough it out into the container. For CSF sample, now for CNS infections, CNS samples for culture include CSF obtained from subdural tap, ventricular aspirations, and lumbar puncture. And three separate tubes for CSF fluid are submitted: one for cell counts and differential stains, and one for gram staining and culture for microbiology, and one for protein and glucose. And also it can be sent for syphilis, like VDRL and RPR test, and for cryptococcal antigen. Here, for CSF, you need to remember one important point. After collection, if there is a delay in processing or transporting to the laboratory, CSF should never be stored in refrigerator. We can store the urine sample in the refrigerator. We can store sputum or pus samples sometimes in the refrigerator, but never a CSF sample because some delicate organisms like Neisseria and Haemophilus influenzae will be killed under low temperature. So they cannot be isolated. And ideally, the CSF should be stored at room temperature. But if you are planning to isolate some viruses, CSF sample can be stored in refrigerator. Now coming to the body fluid sample collection, we have pleural, peritoneal, pericardial, and synovial fluid, which are collected by aspiration through needle and syringe. They should be transported in sterile containers. 1 to 5 ml of specimen is adequate to isolate most of the bacteria, but the larger the volume, better the isolation. Never transport the fluid in a syringe capped with a rubber stopper because recapping and removal of the needle will be unsafe. Sometimes we have seen some needle stick injuries. So always try to transport in some anaerobic transport vials where that can be used for isolating both aerobic and anaerobic pathogens. And specimen meant for recovery of fungi and mycobacteria, they can be transported in sterile screw cap tubes. And coming to the collection of genital secretions, in males, if the urethral discharge is scanty, exudate may be expressed from the urethral orifice by gently milking the penis. And if material is not readily obtained, a tip of a cotton, dacron, or rayon swab can be inserted 3 to 4 centimeters into the anterior urethra. If it is a chlamydal trachomatis isolation, swab should be rotated 360 degrees to dislodge some of the epithelial cells because these are intracellular organisms. In females, samples are mostly obtained from uterine cervix and urethra. Tip of the swab is inserted few millimeters past the cervical os and rotated firmly to obtain both exudate and cervical cells and removed carefully not to touch the vaginal walls. Sometimes and mostly, urine can be a satisfactory specimen to diagnose infections in men and women. And from the genital ulcers should be cleaned to remove the surface debris and contaminated bacteria first before you take the specimen from the base of the ulcer. For intact vesicles, swab is used to collect fluid and placed in suitable media for bacterial culture. Now, automated specimen processing, incubation, antimicrobial susceptibility testing has enhanced the laboratory efficiency, quality, and turnaround time. Definitely. And I want to touch few things in automation in my clinical microbiology, where the time may not permit to touch or to cover all the things of automation in clinical microbiology. But I want to touch a few things which we do regularly at Vijaya Diagnostic Center, so that we can give a rapid and an accurate report for the patient benefit and the better outcome of the patient. Why these automated blood culture systems? What are the advantages of it? If you think, they have a continuous monitoring of whether the pathogen is present or whether the pathogen is present in the particular blood sample or not. There is a continuous monitoring will be there in these automated systems, and they are more sensitive. They give rapid reports. If there is a pathogen or if there's a bacteria growing inside the blood culture bottle, definitely it will flag positive within 1 or 2 days. And it is less labor needed also, because there is no need of subculturing, there is no need of doing subcultures on the alternate days and all these things. So definitely it will give a very rapid and less labor report. But there are some disadvantages on the other side of the coin. Can cost a little bit higher, and sometimes with the conventional bacterial blood culture bottle, we can see the morphology, colony morphology, and we can assess what is that. That we cannot see because the bottle is placed inside the machine, and there is certain detection in the mixed growth, and sometimes increased overgrowth of contaminants can occur, and sometimes the disposal of radioactive materials is can be a disadvantage for this kind of automated systems. We come across this kind of automated systems like Bactec from BD Diagnostics, Bacterial from Biomeru, and ESP system, and they all use some use Bactec uses radioactive isotopes for diagnosing this. A fluorescent compound can be used, whereas in Bacterial they use calorimetric method that I'll discuss in coming slides. These are the blood culture bottles where Bactec or BD Diagnostics uses for blood culturing, and this is the machine that we use regularly in BDC from Biomeru. We have these blood culture bottles. We have color coded bottles. Yellow is for pediatric, green is for adult, and some are for anaerobic culture also. We can place the bottle inside these machines, and this machine has a continuous monitoring of the sample that has been kept inside the bottle. And this is how a calorimetric sensor at the bottom of the bottle detects the carbon dioxide production, which is a byproduct of microbial growth. If there is a bacteria growing inside the bottle, the bacteria utilizes the metabolites and it will release carbon dioxide. Once the carbon dioxide is released, the sensor at the bottom of the bottle that changes its color into yellow, so that is picked up by the machine and it will be flagged to be showing in the monitor, so that we can take the bottle out immediately and subculture it, and we can put antimicrobial susceptibility testing for that. This is another system, Versatrack. And now coming to the identification of microbial organisms or bacteria through automated system. We have Phoenix, we have Vitec MS, which utilizes Malitoff technique. We have Vitec 2 Compact, and we have the microscan walkaway system from Beckman Coulter, and we have BioFire also. This is from Phoenix. This is what we use at BDC. Even in Nandyal, we have this Vitec 2 Compact system, where we put the culture that we have got from the sample, and we will keep them in the tubes, and we'll put the cards. There will be separate cards will be there for gram positive organisms and gram negative organisms. So we will specifically select those cards, and we'll put the cards and put them in the machine, and immediately it will give us a report what organism is there, and what are the antibiotics that are susceptible, and what are the antibiotics that are resistant for that particular isolate. And this is Vitec 2 MS, which utilizes Malitoff mass spectrometry, that is matrix assisted laser desorption or ionization time of flight. It identifies the microorganism within minutes. You can get the report, put the colony of bacteria over the slide and put it into the machine. It will give you what bacteria it is or what organism it is within minutes. It works on ionizing microbial proteins from a pure colony. It measures their time of flight across the tube and comparing the resulting mass spectrum against the comprehensive database that it contains. And this is how the slide will look like, where we put the sample over the slide and put it in the machine. It will give the report. Now we have BioFire from Biomeru, which is an industry-leading molecular diagnostic tool it utilizes syndromic and multiplex PCR technology to detect pathogens like bacteria, virus, yeast, and parasite roughly in 1 hour. So we can put the sample directly into the pouch or the panels that are given, shown here, and we'll put it in the machine. Within 1 hour, we will get, especially it is very useful for pneumonia cases, for meningitis cases, whether it is bacteria, whether it is a viral pneumonia, or whether it's a bacterial pneumonia, even for meningitis case, whether it is tubercular, or viral, or bacterial, we can detect within 1 hour what is the pathogen that is there inside that sample. And it is very, very helpful for the clinicians to give appropriate treatment, and it will really help for the better outcome of the patients. Now we touch on molecular methods. So we have PCR, we have real-time PCR, we have multiplex PCR, we have ligase chain reactions, and transcription-based amplifications and nucleic acid sequence-based amplifications. And I think the time will not permit to explain all these things, but these are the things we have for rapid and accurate diagnostics, especially in clinical microbiology. Finally, uh, we as a lab medicine specialist and clinicians coming together is just the beginning of a great progress. And working together definitely brings a success in the patient's treatment and the better outcome of the patients and proper treatment, and that really helps for the betterment of patient. So thank you so much for this wonderful opportunity, and uh, over to you, madam. Madhu, madam. Thank you.
Uh, Thank you, Dr. Sachin. That was a very elaborate session on the challenges that we face, especially with the uh, clinicians that we for with respect to the sample collection as such. That was a really very insightful session. Now, let us talk about what are the problems that we face with the clinicians, especially, I mean, in a microbiology laboratory, when I'm sitting in the lab and when I'm looking at the plates, there are some, mind-boggling things that happen to me. One of them is, a urine culture which has been collected by a female patient, which is the most problematic thing for me. Probably it is we don't give our collection procedure properly to the patient, or the patient does not understand, or whatever. At the end of it, in my plate, I'm seeing multiple microbial growth as such, and then I'm unable to understand whether the patient is actually having an infection, or whether it's a contaminant flora, or what's happening, especially with the patient. So this is one of the biggest challenges that we have. And I'm not saying that's the biggest challenge, but then this is one of the challenges that we face when I'm sitting in front of a biosafety cabinet and I'm looking at a plate. Right? I'm sure the microbiologists here also would agree. Don't you agree, Dr. Sachin, with this?
Definitely, madam. Yes,
Yeah.
absolutely.
Yeah.
Absolutely.
Yes, and a male patient would be a little okay with this kind of sample collection with the urine, but the female patient, we have to give them a handout. We do give them a handout saying that this is my requirement. This is how you collect a sample. But sometimes we are at loss. We just lose out the pathogen in the commensal flora as such. That's one of the problems that we have. The other one is, when there is an indwelling catheter. That was very nice of you that you presented the indwelling catheter thing, because many of the clinicians or many of the nurses who actually collect the sample from the indwelling catheters do not know how to collect a sample. This presentation would really help people to know from where the sample has to be collected and how it has to be collected, and the main important thing, how not to introduce organisms causing a hospital acquired infection to the patient as such. That was a very nice insight into it, Dr. Sachin. And then we do receive some Foley's tubes as such. I don't know. This is a thing that we've done very early in our PG period, and I'm sure many people have stopped sending these Foley's catheters and the tips now. But then we do receive some on some days. We just reject those samples, but this is just a insight to the clinicians, to tell the clinicians that uh, the Foley's catheter tips are not really okay for because we it is not the suitable sample for a urine culture as such. So please restrain from these kind of samples being sent. And I'm sure one more challenge that we face with respect to blood cultures is we don't get a paired blood culture, right?
Yeah, exactly. Exactly.
Yeah, and by paired blood cultures, I mean an anaerobic and an aerobic blood culture, which we rarely get, especially because we are not a part of a hospital. So we rarely get these kind of samples. If the clinicians could actually insist on sending a anaerobic and an aerobic blood culture, it would be really helpful for us. And the other challenge that we face in the microbiology laboratory is the amount of sample. We keep getting requests, or we keep getting blood culture bottles which are not improperly filled. So it's very important that the clinician or the person who's drawing the blood culture understands that a blood culture bottle has to be filled appropriately with the correct amount of blood, so that we recover the pathogens correctly. Because as we know, in a septicemia, the load is really very less. And until and unless we have the amount of blood that we require, will not be able to give isolate a pathogen from the blood culture bottles as such. And the timing of the blood culture as well, as you said, rightly said, it should be before the, if the patient has been started on an antibiotic, then it should be before the next dosage of antibiotic. And if it is, we are, as microbiologist, I think I would be very happy if the sample has been sent before starting an antibiotic. But then, even before the clinician sees a patient, the patient itself must have taken himself must have taken an antibiotic, right? So it's a normal thing in our country that because of the over the counter availability of blood cultures of antibiotics, we just take antibiotics left, right, and center. Everybody takes antibiotics. They have a throat pain, they just start off themselves on an azithral or an erythromycin or something like that. So everybody takes an antibiotic then and then visits the clinician. So for us, the challenge is always the antibiotic being started before the sample is being sent to the microbiology lab. Our yields are lesser. We get this feedback from the clinician saying that the the culture is sterile. But then these are the challenges that we, as we sit in the microbiology laboratory in front of the plates, this is the challenge that we face, right? And but as I've seen, in my experience, I've seen people now, the clinicians actually insist on sending the sample even before it comes over, sending the sample even before they start the antibiotic, which is a very good thing. I'm seeing this trend now that, the doctor actually tells the patient, please give the urine sample and then start the antibiotic. That culture has started, but we are it's still in the starting of the road. I think there's a long road ahead for us. What do you say, Dr.
Definitely,
Sachin?
madam. Definitely. There is an improvement. Definitely, there
Yeah,
is an
definitely there's an improvement,
because of
right?
the rising antimicrobial resistance and all the things. Even clinicians are very
Mm-hmm.
much aware of this
Yeah.
kind of collecting things.
And nowadays we are seeing
Yeah.
these DGCI inspectors also going to the pharmacists, and then they are, maintaining, they're seeing their records, how the antibiotics, the Schedule H drugs are being dispatched and all of it. So there is definitely an improvement, but a long road ahead for us
Yeah, yeah,
to reach there where we have to.
definitely agree with
And I think the other challenge that we have is definitely with the sputum samples,
you.
because the sputum samples are salivary contaminations.
Yes.
I don't know. We leave it to the patient. We tell the patient that this is how the sample has to be collected, but somehow many of the sputum samples that we receive are saliva. Unfortunately, especially when it comes to recovery of acid fast bacilli, or when it comes to a stain, just a sudden stain, then it's really very difficult for us to report on a sputum sample with a salivary contamination. It's mostly saliva that we receive. So these are the challenges that we face. And then that was a very nice topic that you delved upon, talking about biofire. I think biofire is a platform that we have at Vijaya. And
Yes.
then it's a syndromic approach when the clinician suspects that there are he doesn't know what the patient is suffering from, whether it's a viral meningitis, whether it's a bacterial meningitis. He can just send the CSF sample across, and then we can perform a biofire on that, and we know what is the pathogen. Maybe we'll not be able to give an antibiotic susceptibility testing, but then we do detect for MEK genes and MRSA detections as well. So ESBL detection and MRSA detection are also possible on BioFire.
Yes.
So with this kind of an approach, I think we'll be able to give a quicker diagnosis to the patient, isn't it?
Yeah, definitely, madam. Even they
Yeah.
can start empirical therapy also, knowing whether it is bacteria or virus or
Yeah, they can actually start an empirical therapy based on the organism as such. So
yes.
that is really very helpful. And then I come from a different kind of a background. When I started my career at a lab which does not have so much lot of automation, and I'm amazed at how much of automation we have in Vijaya Diagnostics. And then when I saw the actual thing, that is something Vitachem is,
Yes.
that is something a microbiologist dream, I believe,
Yes.
looking at a Vitachem in life. Okay. And
Yes.
then when I saw the Vitachem, I was like amazed. And when I saw it perform, I was like, wow, this is such a beautiful machine that you just give the culture, and then it will tell you what kind of organism is growing in that within a minute, within few minutes actually. That is an amazing technology that we have. So which reduces the time to detection and helps in diagnosis of any infection as quickly as possible. So we at Vijaya have very good technology to help us out in giving a quicker diagnosis to the patient. So this is what is it about the rapid things that we have, the rapid technologies that we have at Vijay, and the rapid technologies that are available and as a whole in the microbiology segment as such, and then the challenges that we face, especially with the sample collection procedures. Thank you so much, Dr. Sachin. Now, it's open to any questions. Any questions from anyone who's listening to this webinar? Any questions? I think it's just you and me talking to each other, Dr.
No,
Sachin,
madam,
right?
there are few people. I think there are few people.
Okay, since we do not have any questions, I think we can close this webinar. Yep.
Definitely, madam.
Thank you so much, Dr. Sachin, for taking out your time and giving such a elaborate presentation. Thank you so much.
Same here, man. Thank you so much, madam. Thank you.
Yep.